Welcome to the Capstone Conversation, where you learn about what's happening in the greater East Bay. I am your host, Jared Asch. Today, we are going to look at the rapidly changing field of healthcare and hospitals throughout Northern California. We're going to take a look at how technology is changing in the use of AI. We're going to look at lessons learned and the world post-COVID. And one of the hot topics is, what are the impacts of the big, beautiful bill from the feds here, and how does it impact local hospitals in California? Today, I am joined by Bryan Bucklew of the Hospital Council of Northern and Central California. Bryan, thank you for joining us.
We are part of the whole family of the California Hospital Association. There's 3 regional associations in California, San Diego and Imperial counties, and then the Hospital Association of Southern California, which covers the 6 Los Angeles counties. And then you have the Hospital Council of Northern and Central California. We represent 50 of the 58 counties. We go basically from San Luis Obispo over to Visalia, all the way up to the Oregon border, and from the Pacific Ocean over to Nevada. It's a very diverse area. In our area, we have hospitals that have 8 beds, and then we have hospitals that have well over 1,000 beds. And then located in urban areas such as San Francisco, Oakland, Sacramento, Fresno, to very rural areas where there's not another hospital within 100 miles. Critical access, rural hospitals, nonprofit hospitals, investor-owned hospitals, county hospitals, district hospitals. We really cover the gamut in our 50 county service area. And we represent about 214 hospitals in that area.
That is a big and very diverse region to keep your hands on. I appreciate that. How long have you been in the organization, and what is your background?
I moved here, and my family moved here about 7 years ago, almost to the day. I was here a couple months earlier than my family. The rest of my family moved the day of the Paradise Fire. That was something that is indelibly etched in our memory. I came from Ohio. In Ohio, I ran the Greater Dayton Area Hospital Association, which represented hospitals in the Dayton-Cincinnati area. Before that, I was involved in economic development, running public policy and economic development for the regional chamber there. And then before that, I was district director for the member of Congress from that area. But I've been involved in healthcare now for almost 25 years. It's evolved a lot in those 25 years, and it's evolved a lot in the last 25 minutes, it feels like.
Use that as the lead in. Let's talk post-COVID. There was a lot of lessons learned. A lot of staff have burned out. What have we learned, and what are we doing to improve going forward in the hospital network here?
Yeah, there's some positives that came out of COVID. We've been able to deliver care, I believe, more efficiently and effectively through telehealth, and realizing that sometimes the most efficient, effective way to get care to somebody is maybe not visiting in person. Telehealth has become more of a standard operating procedure. We're still operating on some waivers and some exemptions right now, but overall, I think that's increased the accessibility to healthcare for a lot of individuals. And that's something that we found out during COVID. Also during COVID, we found out that our system has been set up not to focus in on inpatient, and has really been focused in on the outpatients. The number of beds have decreased per capita. And the reason for that is for a number of things. One, we have a lot shorter length of stays, and that's primarily because the technology has increased so significantly in the past. I remember when I was a kid of 6 or 7 years old and I had my tonsils and adenoids taken out, that was a 3-day hospital stay. And now you're lucky to be in, if you're even in a hospital, or you may be in a surgery center, but that's maybe a 3-hour procedure from the time you show up to the time that you leave. The medical technology's increased dramatically, which requires less of an inpatient footprint. But the requirements for hospitals to be available 24 24/7, 365 days a year remains. And hospitals, what we found out during COVID, are really the bedrock of the healthcare system. And when issues came up during COVID, whether it was the identification of testing, distribution of vaccines, it all went through the hospitals. It didn't go through really the public health entities in the state or at the county level. They're really going through the hospitals, and the hospitals were looked to as leaders in that area. And I think that continues today. We had to basically figure out overnight. The first time that I remember hearing COVID was in late January of 2020. And then the first case that we know of in Northern California and really all of California, and one of the first in the entire country, was at North Bay Health, which is in the Central Coast area, in the East Bay area. I remember getting a call on February 29th, and they had taken a test. And at that time, you had to send those tests back to Atlanta. You weren't able to process the test remotely. You had to go back to the CDC. And that test was administered about 8 days prior to them getting notified on February 29th. And at that time, you had a number of people going in and out of that room where that patient was. And it was a very challenging time. And by February 29th to basically March 16th, the entire state and the entire country shut down in those 2 weeks. It was a very quick period of time where everybody was trying to figure out what was going on, how do you identify it, and more importantly, how do you treat it, and how do you make sure that the healthcare system is set up to do that? Basically, you're learning to fly the plane while you're building it. And it was a very challenging set of circumstances.
One of the more fascinating things I took away with what you said is that tonsil surgery is going from 3 days to 3 hours really has to do with recovery, the process for the procedure, the use of lasers. On the telehealth side that you talked about, where are people seeing the biggest uptick? Is it in those rural areas who have to drive 30, 50 miles to a doctor? Or is it in the urban areas because it's just more accessible? I know I've had doctors in Southern California do telehealth, which was easier to get appointments with than people here in the Bay Area in person.
This is one of those circumstances that's somewhat unique to healthcare, that it's ubiquitous across the system. There's benefits in the rural areas and the critical access areas, benefits in the urban areas, also in the suburban areas. And what it does is it allows the dissemination and the identification of certain ailments to be able to be done remotely, and then being able to get treated for that remotely. When I had COVID, I had a video appointment and I was able to get prescribed the medicines all remotely. I didn't have to go in at all to the facility. And I think that brings more access. And that's a critical component to what you're looking for in healthcare, is making sure people have access to the care that they need when they need it. Our mantra is, how do you get people the right care at the right time in the right facility for the right cost? And telehealth really helps move that forward. Prior to COVID, you really had to go in to get a prescription. Prescriptions weren't done via telehealth. And this really fast forwarded the regulatory process to approve telehealth. COVID really normalized that process and made everyone realize that there was a capacity to really provide some access and some treatment in the telehealth medium.
You talked about they're still on waivers. Is that going through the legislature to pass a bill to clarify that and allow that long term? Or what
Yeah.
is needed from a policy perspective?
Yeah, there's a couple things. One, the way the healthcare system is set up in our country is a conglomeration, a number of different rules, regulation, and legislation that happens at the local, state, and federal level. And not all of those work well together. And part of this is some CMS, which is the Center for Medicaid and Medicare Services, which is part of HHS, which is the federal regulatory body. Some of this is the state. And those are the two major areas where you get flexibility on waivers that are done for a certain period of time. And at some point of time, those waivers expire. For example, during COVID, hospitals were able to get waivers for flex space, meaning that you could treat patients in non-traditional areas of the hospital because you needed the room, and you were able to get some flex space waivers for that. Hospitals to set up triage areas and parking lots, and individuals that potentially had COVID didn't need to physically come into the facility to get tested. They could be tested in the parking lots. All of those have waivers, and healthcare has a significant legislative and regulatory requirement. And in California, it is more robust. And that's a politically correct way of saying that the legislative and regulatory culture in California is much more significant than any other state in the entire country. I have experience in other states, specifically Kentucky, Indiana, Ohio, much different regulatory process than we have here in California. Some of it's good, and some of it's challenging, and some of it's maybe not necessary, but it's the waters in which we swim in and that we have to deal with.
For those of you just listening on the audio, you can see my shocked face because California has more regulations than any other state. I didn't think that would be possible. There are these things that the agency, the legislature are starting to look at, like how to evolve longer term, or are they happy with some waivers and see where things go in the next couple of years?
I think there's a couple of things. State and federal governments and private payers want to make sure that what they're paying for healthcare has some checks and balances. That's why you have some of these temporary waivers. Previously, there was some concern that, well, why would you pay a physician or a hospital the same amount for a telehealth visit as for an in-person visit? As they go through those public policy discussions, they know that, at least from a temporary standpoint, keeping the telehealth policies in place makes a lot of sense because it provides access to individuals. It's a legislative regulatory issue. And I think the challenge is that, and I think for your listeners, if you go into a hospital today or a doctor's office today, generally, and I'll leave it at hospitals because I'm much more familiar there. On average, you're going to have somewhere between 70 to 82% of the individuals in that facility, in that hospital, on a government plan, either a Medicare or Medicaid plan. And the vast majority of those costs those hospitals are getting, and physicians are getting reimbursed at less than it takes. If you can imagine, you're going to open up a business and say, hey, we're going to guarantee that there's going to be a demand for your product or service. You have to be open 24 hours a day, 365 days a year, 7 days a week, and there'll be unlimited customers coming through your door. But you're going to lose money on 80% of the people walking through your door. I'm not sure many people would want to go into that business. And that's the challenge that we have in the healthcare industry. And the other challenge that we have is it is not set up to make long-term financial systemic change in the system. And the reason for that is when you have 80% of your patients being covered by either the state or federal government or a combination thereof, it is more looked as a budget item that has to be approved 1 year or every 2 years in terms of how much you're paying for certain types of services. And that makes it very difficult to do some long-term planning associated with that. The healthcare economics follows no other rational economic model. And I remember doing a lot of town hall meetings during the Affordable Care Act or Obamacare. And I did town hall meetings where predominantly the number of people there were supportive of universal payer, and then others that were Tea Party back in the day, where they wanted the free markets. Free market should dictate healthcare. But as soon as you start talking to him about Medicare, which is not part of the free market, then he's, don't take away my Medicare. That's a significant part of the healthcare system. And you have to get in the philosophical, but it gets down into to realistic, is if you look at everyone that participates in the healthcare system, the incentives are not aligned to figure out how to get you the best care at the best price, because you have incentives from all the different players in healthcare, whether you look at physicians, medical equipment suppliers, pharmaceutical companies, insurance companies, whether they're for profit or not for profit, Medicare, Medicaid. Some of their goals are their ultimate customers, the shareholder. Some of those are the patient, but none of those are aligned. And when you have a system that has so many different players and have so many different end users that they're looking to satisfy, it makes it very challenging to do systemic and fundamental change.
I want to hit on that. You said if I look at all the hospitals like in the Bay Area as an example, right? There's a lot of big ones. Sutter Health has multiple hospitals. You've got UCSF, Children's Benioff, Kaiser, all of those. You're saying, John Muir, 72 to 80% for health is government backed.
Yep.
Okay, let's use that as a pivot point to dive into the one big, beautiful bill. Tons of changes to both of those federal programs and a lot of impact to the hospitals. And we'll just focus on the hospital related side. That's your expertise. Give us an overview of the impact you're expecting in Northern California and Central in your territory. A lot of questions about people losing coverage, a lot of people losing federal incentives, rural hospitals just losing a lot of backing. Give us a quick overview and then we'll dive in.
Yeah, unfortunately, there's not a lot of specifics except for there's going to be massive change. There's going to be a lot less money going towards healthcare than there was previously. And in some cases, Alameda Health is looking at an annual impact of $100 million a year in lost revenue. You're looking in San Francisco, grants and HHS grants and NIH grants and research, upwards of $1 billion a year being taken out. In Santa Clara County, you're also looking at $1 billion being taken out. You look at individual hospital systems like North Bay Health, they're looking at a direct impact of anywhere from $15 to $30 million. There's some significant dollars associated with that, legislative issues that they wanted to help offset the cost. And when you look at some of the biggest drivers of government spending, it is in healthcare because we already talked about 80% of the people that are utilizing the healthcare system today are either on a Medicare or a Medicaid or some combination thereof plan. And that was the largest dollar amount. And there really was next to zero discussion on healthcare policy. It was really looking at how much was the cost that they could extract to be put towards other priorities. And the challenge now is we got to figure out how that system is going to be put together because while the public policy on healthcare delivery really wasn't discussed, the impact is massive. And now we are left, we hospitals, we as healthcare, we as public health, we as universities have to figure out how do we operate with the much less funding than we had before, and what are the coverage implications of that? We have a kind of a perfect storm of a crackdown on immigration. We've already seen the number of individuals with uncertain immigration status here in California utilizing the healthcare system a lot less. That doesn't mean they're not going to use it at some point in the future, but they're delaying care. We've seen examples of during COVID and during the closure of other hospitals, when you delay care, when they come back into the healthcare system, that care is much more acute, much more severe, much more costly. Everybody's trying to figure out what the actual implications are. And we're not getting a lot of direction right now from Health and Human Services, from CMS on the federal side, because they're trying to figure everything out. The state's trying to figure everything out. And it's just a very challenging environment. Will, I think, really be at the forefront in 2026. I think the actual cuts to healthcare and the funding, we really won't see the most impactful things occur until late 2027, 2028, because some of these cuts don't go into effect until some of the out years. and there's some politics involved in that. But we basically have maybe about 18 months to try to figure out how to navigate in these new financial waters and have a lot less resources to provide the care that people have been expecting.
Let me dive in to some stats that the California Hospital Association put out about that. 15 million of the close to 40 million Californians, which is about 38% of the state, are on Medi-Cal. That's the low income program. 30% reduction pretty much across the board for that. What is the impact on that? You're talking it was already done at less service. Is it just less people having insurance now? Are they cutting 30% off, or do they make that up because they cut out care? Help us understand that.
I think these are individuals that are going to be losing coverage. And what happens there is hospitals are required, from a federal perspective, is to provide care for anyone that shows up at the ED department. And regardless of their ability to pay, that's why we have been seeing a significant increase of individuals going to the ED for non-emergent issues, earaches, sore throats, those things. And that really is the most expensive way to do any type of care. Additionally, individuals that have chronic disease, whether it's pulmonary disease, diabetes, oftentimes they show up at the emergency department for some symptoms related to that. And not really, it's really difficult to manage their care through the ED department. And if they don't have coverage, they're not going to see a primary care physician. They're not going to have a medical home. They're going to delay care. And then when they do show up into the healthcare system, it's going to be much more costly to treat. Right now, we have about a 3% to 4% uninsured rate here in California because we've covered everyone, at least through Medi-Cal and through other payer systems such as private insurance, some public insurance cover California, also with Medicare. That could go up at 13, 14, 15%. What that means is individuals will still get care, but it'll be uncompensated care. And then that raises a cost for everybody. This is what everybody's trying to sort out now to figure out how many people are going to delay care, how many people are not going to access the system when they should be accessing the system. And the challenges that we're going to have, I think, will be immense. I do think we have a recent experience here in California to look at. Madera Community Hospital closed. It was closed for almost 3 years. And during the time it was closed, it also closed 3 rural healthcare clinics. And what we saw is you had individuals that couldn't access care to the next closest hospital because the next closest hospital was either in Southern Madera or in Fresno because they didn't have a car. We saw adults pass away in a pediatric hospital at Valley Children's because that was the closest hospital to Madera. And they would go for healthcare. Adults would go for healthcare at the children's hospital. And then you saw double and triple digits of increase of utilization for hospitals in Fresno of people traveling from Madera for various conditions, including maternity health, OBGYN services, mental behavioral health, because those services weren't available in Madera. And that was just one hospital. And it took once that hospital closed, it took 3 years for that hospital to reopen. It's very difficult to reopen a hospital. And what we've seen here in California and what we've seen across the country is that I think elected officials think that as long as the hospital's open and the ED's open, everything's great. But what they don't see is the death by 1,000 cuts. When you have service lines being cut, whether they're cardiac services, OBGYN services, mental behavioral health services, those are all services that hospitals, when they have to make difficult decisions in either to keep them operational or to find the employees to run those service lines, they close those service lines. And while the hospital technically is open, the amount of care and the type of care gets pushed out to other areas, and it makes it more difficult for people to access care. And so that's why we talk about access as such a critical component. And we think that's going to have some critical implications with this one big, beautiful bill.
You're talking 20 to 25% on average of users then have corporate insurance, right, through their employer. How are those people impacted by this? Because the hospitals have to make up the rate. Wouldn't that dramatically increase the cost to those? Or those are fixed costs, right? It's the insurance company says it's $500 for this, and that's all the hospital gets.
We have a regulatory body that the state has recently created called the Office of Healthcare Affordability, which looks at the goals. How do you keep healthcare affordable? It seems their laser target is on hospitals when over the past 5 years, hospital costs have increased on average between 3 to 5%. And if you look at the target that they're looking at, it's in that area, whereas insurance rates have increased by over 20%. And those are costs that companies pay, individuals pay. And I think as we get back to talking about how we develop a healthcare system, is I know of no other commodity or service that people utilize on a regular basis and have no idea on how much that service or commodity actually costs. Because for somebody like me that has insurance, I don't pay the full cost of my insurance. My employer pays part of that insurance. I pay part of that premium. I may have a copay or have a deductible, but I don't know how much that costs. Just like with the Affordable Care Act, there were certain essential health services that were identified that were quote unquote free. They were free for you, they were free for the user, but for the doctor or the hospital that was providing that service, those aren't free. And those costs have to be accounted for in some way. And that's why the incentives are all misaligned. And it is a big challenge. When you have this amount of financial shifting going on and the amount of money that's being taken off the table by the state and federal government, you're going to see a combination of service line closures. You're going to see hospitals close. You're going to see rates increase in certain areas. And it's going to take a while for all that to play out. I think different individuals will have a different financial impact. But I think most importantly is the services that you look forward to today that may be accessible in your area may not be accessible in the future. And then you have to travel a significant distance in order to access those services.
Will those cuts still happen in the Metro Bay area, or there's always another doctor, I guess, if you could pay for it, right?
Yeah. And I think California is a microcosm of the entire country. And you have some areas that are going to be greatly affected. Some areas are going to be less impacted, but all of them are going to have some financial impact. I think in the Bay Area, when you take $1 billion out of Santa Clara County, you take $1 billion out of San Francisco, and you take hundreds of millions of dollars out of Contra Costa and Solano, those all have significant impacts. I think to think that you're going to have the same type of services and the same access to services is a challenge. I think what you're seeing with the systems in the Bay Area and in the East Bay Area is how can they efficiently and effectively provide those services? I think you're seeing a lot of investment in outpatient and ambulatory areas and making the hospital less of the central area of where you get your primary care. And I think you're seeing a lot of investment, whether you're Kaiser, whether you're Sutter, UCSF, Alameda Health, John Muir, all of the North Bay. They're looking to how do we provide that care in communities and how do we do it in the most efficient, effective way? And I think that the delivery of care is going to change.
And I just want to throw numbers out. The Hospital Association California says the impact to the state is somewhere between 66 billion and 128 billion cut in the next 10 years. That's a wide estimate because you said they still have rules to write, programs to figure out as this rolls out, which will change that fluctuation. But even if each county loses about $1 billion local aid, that's 10 billion in the region, right? In the 9 county area, maybe 10 billion. That's significant. And that can't be made up in philanthropy, right? Sure,
Right.
philanthropy will close the gap, but not 9 to 10 billion. And that will have a trickle down economic impact. And even more so in those rural areas you're talking about, it will impact lunch places and people's take home pay, and jobs will have to get cut out of those numbers as services change. You've said you've done economic development. Just any thoughts on the overall budget too as those services change?
Yeah, I think it's going to be a challenge for everybody. It's going to be a challenge for businesses. It's going to be a challenge for the state. Taking that much money in a 10-year period of time, if you take a 10-year horizon, it's going to require literally transformational change in the healthcare environment and the healthcare delivery system. And the one thing that California is not set up to do on a state level and on a regulatory level is transformational change and to do it quickly. And hospitals are trying to figure out, how do we operate within the regulatory framework and then also being able to finance this. And then ultimately, how do you provide the care to the patients that they're trying to serve day in and day out? And that's what's keeping everybody up at night.
Yeah, that's a lot going on. And it sounds like the bigger impact could be to these rural places that might not have other options.
But yeah, and I think if you have a hospital that is hundreds of miles away, hours away from the next closest facility, it's a different level. But they also don't have the economic base as maybe businesses and hospitals in the East Bay or the Bay Area. That makes it very challenging. They just can't automatically find a bunch of dollars, find a lot of philanthropy. And at the same time, hospitals are still trying to upgrade on seismic. And some of our hospitals that haven't upgraded to seismic yet are in these rural communities just because they don't have the millions of dollars necessary to update their facilities to the current regulations. All of them have met the 2020 standards. And basically, that means the hospital is not going to collapse during a major quake. And what 2030 requires hospitals to do is remain fully operational after a major quake. And that is significant dollars, all privately financed. All has to be either raised by the hospitals themselves. There's no government funding associated with that. And all of these financial pressures are just exacerbated by now the one big beautiful bill. They were immense before, and now they're daunting.
Let's talk about AI in healthcare. AI is a big topic just in the news and the headlines. We've talked about it from lots of different angles here. What what are you seeing? Are hospitals changing and embracing AI? And can some of that help reduce cost or allow staff to be allocated towards other resources?
The short answer is yes. There's also a concern is like, is AI going to replace jobs? We had an AI conference last year with a lot of the hospitals from the Bay Area, from the East Bay. We had UCSF, we had UC San Diego, we had D. Davis, we had Stanford, all talking about AI in healthcare. And basically, the consensus is that it's not going to eliminate jobs, but it will eliminate jobs for people that don't know how to utilize AI. You're going to have to figure out how to incorporate AI. I just saw something in Becker's today where I think it was UCSF now has over 200 plus AI products that they're utilizing in the diagnostic and in the administrative area. I know insurance companies and payers on the admin side are utilizing AI. That's good. And it's also presents some challenges on making sure that there's some human oversight on that. But I don't think the healthcare system is going to be taken over by AI. I think it's going to be enhanced by AI. We're lucky to be in the Silicon Valley area and have access to this and working with these companies. But it's going to be a critical component moving forward in the future. It's something that I know our rural hospitals are already utilizing because it helps them out. It gets access to care for individuals that used to have to travel far distances. Telehealth, I would say, would be like the infancy of AI. And now you can you can get consults, you can get second opinions with AI. I know from a payer standpoint, both with the federal government level and in the private insurance area, you have AI helping process claims. which is good. But then you also have to be cognizant that prior authorizations or denial of claims aren't done automatically. There's some oversight on that. Once again, I think it's another area where we're learning to build the plane as we're flying it. It's a really challenging regulatory environment, but it's good. There's some areas where doctors have found some of the transcription services when they're meeting with patients, instead of them huddled over a keyboard and having to type everything in, they now have notes that transcribe the conversation with the patients. Doctors feel more connected with the patients feel more connected with the doctors. That has been something that's been very positive. Some of those can get automatically uploaded into the medical record. Some of those can even be coded for payment. But the challenge is, how do you back check that? How do you make sure that there's accuracy there?
I have a police tech company like that, and we're what we say is the officers are still responsible for reading it and signing their name to it, because the systems only pick up, like, they might not pick up what you saw over here on the sides. That's important. Before we leave, any further thoughts that you want to leave the audience with from an impact of changes coming in healthcare or on policy, or both, real quick?
I think that to your listeners out there, be aware of what's going on with healthcare. If you are having challenges with the healthcare system, don't let your doctor know or your caregiver or your system know, but let your elected officials know. Those personal stories do matter. And these are elected officials at all levels of government. In California, a lot of healthcare goes through the county level, especially mental and behavioral health, public health, testing. Please let your board of supervisors know, keep them aware. I know we've been briefing them on the Office of Healthcare Affordability. Please let your state representatives, your state assembly members, your state senators, and then your members of Congress also know. It's really critically important. And this isn't something that we'll figure out in the next 30 days, 30 months, or even 3 years. This is something that we're going to have to stay diligent on. And the healthcare system that we have today is definitely going to be different than the healthcare system we have starting next year.
Wow. Bryan Bucklew, thank you for joining us from the Northern and Central California Hospital Council.